Welcome, everybody. We have a lot of people have come on, so we'll get started. And so, welcome. My name is Rick Trelevin. I'm the chair of this board. And we will start. So Kelsey was going to cover introductions. Okay.
Yeah, we will facilitate there. I'll start with you, Rick, and then Linda Johnson, please.
Oh,
Okay.
go ahead, Rick.
I think I introduced myself. So Linda.
Okay. Linda Johnson, Health Council Community Representative and Chair of Governance Committee.
Commissioner Adair and Dr. Allen.
Patty Adair, Deschutes County Commissioner. Happy afternoon.
Gary Allen, Vice President, Clinical Services, Advantage Dental.
Eric and Paul.
Eric Alexander, Partners in Care.
Paul Andrews, Superintendent, High Desert Education Service District.
Megan and Brad.
Megan Hayes, Mosaic Medical.
Hi there, Brad Porterfield, Consumer Representative and Community Advisory Council Chair.
And Iman, welcome to your first meeting.
Thank you for having me. Iman Simmons. I serve as the Chief Operating Officer at St. Charles Health System.
All right, we'll go through the Health Council staff, Michaela and Rebecca.
Michaela Arsenault, Project Manager at the Central Oregon Health Council.
Hi all, Rebecca Berry, Grants and Metrics Manager at the Central Oregon Health Council.
Gwen and Donna.
Gwen Jones, she, her, hers, Project Manager.
Good afternoon, everybody. Donna Mills. I serve as Executive Director for Central Oregon Health Council.
Renee.
Renee Worth, Project Manager at the Central Oregon Health Council.
And I am Kelsey Seymour, Administrative Assistant and Media Coordinator at the Health Council. We have some guests with us today, Kat and Leslie.
Hi, Kat Mastrangelo, Director of Volunteers in Medicine, also a member of the Operations Council.
Hi, Leslie Neugebauer, Director of the Central Oregon CCO at Pacific Source.
Thank you. Kristen and Gretchen.
Hi, Kristen Tobias, Community Health Coordinator for Pacific Source.
Hello, Gretchen Horton Dunbar, Project Manager, Pacific Source.
Awesome. Since we started, we've had 2 board members join us. Welcome, Justin and Dan. Can you introduce yourselves, please?
You first, Dan.
I was going to say the same thing. I'll introduce you, you introduce me. No. Hey, Dan Stevens with Pacific Source. Good afternoon.
Justin Civil with Summit Medical Group, Oregon.
Hey guys, this is Divya. I'm on the phone. I'll be able to video in at 1, but I can't until 1. Just Divya Sharma Kwepa.
Thank you so much, Divya. You were going to be my last one since I didn't know who you were. Excellent. That is everyone. Did I miss anyone at all? Please speak now. Okay, we're going to call it good.
Okay, and then just a reminder to the folks who've just jumped in, please put your name in the chat box. It helps with documentation. Do we have any public comment? I see our virtual board is just filled with the general public has come in. Do we have any changes to the agenda? No. So we all, okay. So action items and approved consent agenda. We have the action items and the consent agenda down there. Is there approval to approve? Do I have a motion to approve the consent agenda?
I move we approve the consent agenda.
Second?
I'll second.
Okay. All in favor, say aye.
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 Opposed?
Aye.
I'm assuming, Dan, that that was an aye.
It was a belated aye. I apologize.
No worries. Okay. And so it's approved. And then I think we have Gary for patient story.
Yes, thank you. And the story that I have this afternoon is really to highlight a small nonprofit in our own backyard that does excellent work as far as navigating and sponsoring children for medically necessary dental care. And I know some of you are familiar with Smile for Kids. And it used to be Advantage Smiles for Kids, but they're out on their own now. And the shorthand reference is ASK. And then Central Oregon Health Council has provided grant funding for the organization in the past. So I know that there's some familiarity already. But for those that may not be familiar with ASK, it has a very narrow focus. It provides orthodontic care for children that have severe malocclusion to the extent that they suffer self-esteem issues and oftentimes bullying from their peers. And orthodontics is not covered under OHP unless there's an associated cleft lip or cleft palate. So ASK will step in to provide, fill in the coverage gap to the extent that they can, but orthodontics is very expensive. And there's a long list of children waiting to get into the program. So to stretch their limited resources, they will oftentimes reach out to DCOs, ourselves, Advantage, and other DCOs to try to leverage their OHP enrollment and cover as much as possible to facilitate and prepare them for the orthodontic care. And one child was brought to my attention by ASK because she had a very severe, a very rare genetic disorder that affected the craniofacial structures to the extent that she didn't qualify for orthodontic under OHP because she didn't have a cleft. But in addition, she really couldn't even get braces until there was a major orthognathic surgery correction. I thought this would be a particularly good case to test and challenge what I've, the longstanding and what I've considered or always thought to be the illogical exclusion of orthodontic care for groups of kids with craniofacial disorders other than cleft. They've kind of been left by the wayside, probably because their conditions are so rare, they've never really had anyone advocating for them in the past. And without going through the entire bureaucratic process, which quite frankly took many months, we were able to eventually assemble a group of subject matter experts and advocates that made a convincing argument to get coverage for craniofacial disorders other than cleft lip and cleft palate. So that was a win, but it was just one step for this particular child because of the surgical correction that she needed. And there was no surgical team that was really available to provide the complex correction that she needed. But through serendipity, we were led to Shriners Hospital in Chicago, which we found out was willing and able, had the resources and had the expertise to provide the surgical correction, and was willing to commit to it at no cost to include travel expenses for the child if we would commit to the orthodontics. So that was a win, but a long-term win, because now a Smile for Kids ASK has been able to enter into a long-term partnership and agreement with Chicago Shriners for other kids that might have similar conditions. So it was a long journey, but a very favorable outcome.
Okay, thank you. Any questions or comments? Good. So, Mr. Stevens, the 2020 JMA settlement.
Yes, sir, Rick. Thanks, Gary, for that great story there. So I know this has been talked about at the, I think at the Finance Committee. I was also able to give Linda and Donna and Rick a quick preview of kind of what Pacific Source is thinking here at our exec committee last week. So I know a few of you know this. Just regarding the JMA, so everybody knows that the Joint Management Agreement is really this agreement that governs how the Health Council and Pacific Source work together. We've been super fortunate in many of our years of working together in the CCO that we've had a surplus. And so what the JMA tells us to do, the JMA guides us in terms of how to treat a surplus and how distributions would happen. And I think we all know where we've been there, and that story's been really strong. Most years have actually had a surplus above a 2% net income. It also is instructive on how a less than 2% net income performance in the CCO would be handled. And one of the things that happens there, which has actually been a part of the JMA since the beginning, so since CCO 1.0 in our infancy, is that if there's a less than 2% net income, the CCO, in this case Pacific Source, has a carryover, a recapture opportunity in future years. And it used to be that recapture would only happen in the case of a surplus in the following year. Now, because we changed the methodology by which the Health Council receives dollars to carry out its regional health improvement plan functions, as I think as everybody knows, the Health Council gets 1% of the global budget that the CCO brings in on a monthly basis, in addition to their operating monthly budget funds or their operating revenue. And those are the dollars that the Health Council uses to make some of the community investments, to fund the RIP work groups and the overall work of our regional health improvement plan, right? So a little bit of stage setting there brings me to kind of what the Pacific Source thinking is, and we're communicating this across actually all of our CCOs. We know that 2020 was a really unique year in terms of many things, the pandemic and what that did to encounters and volume and provider revenue, what it did to the tremendous uncertainty of all of those we serve in terms of how to seek care, not to mention just deal with the other challenges of daily life. We also know that the OHA had a number of what we would consider to be one-time 2020 stipulations. They did a retro rate adjustment. It's not that hasn't ever happened before or couldn't happen again, but it's unique. They stipulated that withholds be suspended. So CCOs had to do some work and suspend withholds and make sure we know how to treat that. They also stipulated to CCOs that CCOs should make provider stability payments, so some advance payments to make sure dollars kept flowing into provider and to provider organizations to provide care, continue to be stable and keep access good, and many other things that when we looked at 2020, and as I think a lot of you know, the overall performance in 2020 is below a 2% net income, or projected to be. We don't have the December final figures yet, but we're currently projecting a pretty significant total net income when you think about all the retro adjustments, everything that happens. So fast forward to kind of where we are and what we're wanting to communicate to the board, and we'll be sending a letter to Rick as chair to sign later this week. We would like in all of our regions that had a less than 2% margin performance, for all the reasons I mentioned, to start the year 2021 without any recapture. So we would love to put the community model, the health councils, providers, and those that will enjoy some of the surplus from the 2019 performance, which was just over $8 million. And I see Donna nodding because that check is now in your bank account. You know, there was a chance that some of that was going to have to be earmarked for an anticipated pretty significant loss from 2020 that then gets settled in 21. And our decision as an organization is we think a lot of things happen this year that won't be repeated. We think that if we could start the year without a requirement that the CCO is going to start recapturing those funds from the Health Council on a monthly basis, that would be a good thing to do. So that's what we've offered. We have a letter that's been drafted up. It's very simple. It says more succinctly than I just said that. But in essence, it says that, and the ask is that Rick, as the authorized signature for the Health Council, just countersign that. What it acknowledges is that this is just a 2020 event. It's not anticipated to be something we would do every year. It's different than the language that we have in the JMA, which actually stipulates how the recapture works and that there would be a recapture. And so this is us forgoing that for 2020. And so the letter is really something we felt we needed to do, not to modify the language in the JMA, but just to say, this is something we're doing and we agree in writing and that we're going to do it. So let me pause there. That might have been like, hey, thumbs up, sounds good to some of you. It might have been like, you just really confused the crap out of me to others of you. And so let me pause and ask and try to answer any questions you might have if there are any.
Hey, Dan. Yeah, my brain's kind of all over the place right now. So I'm gonna, if you could please just, this is Brad Porterfield, if you could just state as concisely as possible the normal situation and what you're requesting that is not normal.
Yeah, so normally, Brad, it's a great question, and it is. I know, especially for folks that are new that haven't been living in this world, it's a pretty unique model we have, and not just in the CCO but in the nation. So, Brad, if we have a loss in the CCO against our 2% budget, and by we I mean Pacific Source. So, if Pacific Source's financials for the CCO in Central Oregon have a loss, and Donna, I'll just pick a round number, but it may not be far off from where 2020 is projected to end. A loss of about $10 million, Brad, is what we're projecting this year. That could change based on December. What we are allowed to do in the JMA, because we carry the ultimate downside risk in the CCO, and we share most of the upside risk. So what we built into the JMA is that the CCO could slowly recapture those historical losses. So in this case, we have a process for slowly recapturing what in 2020 amounts to a pretty big loss, bigger than any of us anticipated. And that process would actually start to play out in 2021, once we finalize the loss position, once we have the final numbers. And so what we want to do this year, because of the uniqueness of the year, is to say there is no loss. We're writing off any recapture of that $10 million. So we're acting as if we hit a 2% budget, even though we didn't. That's the essence of it.
Any other questions? Well, I just want to say, as chairman of the board, just how much this show represents Pacific Source being not just an insurance company, but a real community partner in this project. And this is a very, very generous offer. And so I just want to thank you as chairman of the board for this. Very impressive. Any other comments from the board?
This is Megan. We did get a preview of this at our finance committee. Unfortunately, I was kind of given a heads up prior to the discussion. And I just want to share that the finance committee also is really appreciative and very thankful for Pacific Source doing this for us and for the community. And one of the things Donna had talked about is just making sure that we really do acknowledge this action by Pacific Source in the community, because it's very significant to have these dollars stay in a place where they can go out to the community, and if you're making that happen is just very generous. So big thank you to you, and Donna, maybe you could talk about what you were thinking as far as the acknowledgement too.
Yes, and I think that this is just an example of the way that Pacific Source typically operates. So we did draft a press release. However, Pacific Source asked that we didn't push out that press release. And I think I can understand, especially knowing their character, and it might be misconstrued in the community. I mean, to the point that understanding how our model works, to Dan's point about being very unique in the state and in the nation. So we are drafting a thank you note from the board to Pacific Source to Kin specifically. But just much gratitude for how we're going to be able to now follow our 2019 JMA settlement and get those monies out into the community here in the next couple of weeks. So that wouldn't have been possible if there wasn't a forgiveness on this lost position by Pacific Source. We would have literally had to give all of that money back and another $3 million. So again, I can't express our gratitude enough to Pacific Source for this gift for 2020. Thank you.
So I would say thanks to Rick. Please, bring that back to Pacific Source. Rick, I would just ask, so it's just, we get through December, we're into January. I don't know that there was a time period in April or May where I knew that we were on pace to be $10 million over budget. Any concerns that in one of the lowest utilized healthcare years in the history of the country, that budget has been completely pushed past? Do we have general indicators to make sure we're not in this position again next year?
Yeah, I mean, I think the explanation has been about withholds pushed out, QIMs pushed out, all at 100%. And that was the explanation of much of that delta. Dan or Leslie, do you want to expand in a more informed manner than me?
I know that finance has talked about it at some length, and I know not everybody in this room goes to finance on a regular basis. I think what we could do for those who want sort of a different level explanation of some of the big shifts in the financial year that was 2020 and some of the kind of big one-time things that really drove the results. I know that we could probably pick some of the documents that come out of finance and share those, and or somebody could, if you want to just jump on the phone with a Pacific Source person who knows these details more completely, that's also possible.
I think we'd love that. My group would love to be able to kind of compare the results of, it seems like, every other population that we followed through the pandemic, the inpatient utilization, the fact that so many of the ORs were shut down for so long, have driven the lowest spend in our company's history on 20 of our other contracts. So I think we'd love to sit down with you and see how that budget for this singular population managed to be exceeded when it didn't on any other contract we have. And not by a little, it was by a lot. So yeah, we would, I'm volunteering first. I'd love to sit down with you guys and hear those numbers.
That sounds good. Yeah, we can cause that to happen. What I probably should have mentioned in the kind of the summary remarks is that through November, so we don't know December, and it really has been bouncing around a lot. I think I remember these numbers, Donna or others who are at finance, Leslie, the 2020 net income performance in the CCO in Central Oregon, not including one-time or retro adjustment type of events, was 1.56 net income against a budget of 2. So not actually too far off from the 2% and in a positive position. it was everything in this retro one-time category that really pushed it that far to the negative. And again, Justin, we can share some more of that detail.
Dan, wouldn't you say that just the way Medicaid works, because of some of these things, it's not really apples to apples with other payer types and to a certain degree, and then this contract is probably the most capitated contract compared to other contracts that are more on the fee-for-service side, which certainly also has an impact because the utilization, if it's down, the payments still go in some of the categories.
All those things play a role for sure. It does have a lot of unique features to it that aren't replicated in other business segments.
Yeah, I think that's a really important one though for everybody to understand. And in an area where you operate that capitated model, if you have massive declines in OR utilization and bed days of care, you're still going to pay 100% for that. So there's definitely a significant amount of buying capacity that you didn't use. So hopefully that'll get adjusted for in the future since it was overpaid for in a capitated model. So.
Okay. I'm personally proposing Dan get some cupcakes from the council, but we'll work on that.
Is that chocolate, Dan? Did you want chocolate cupcakes or?
Rick, just a real nice bottle of Woodruff Reserve whiskey from your cabinet would be preferred.
Well, you're talking to the wrong guy.
I know I am. I know. That's why I'm talking to you, because I don't need anything. No, this is it takes a village to do this work, and this is something that our CEO felt strongly about this year. We had a negative position in the Marion and Polk, the Salem CCO, and we didn't want to start the second year of that contract with a carry forward or a recapture. And it got us talking about all regions and just how unique this year was. So, appreciate the dialogue and I think where we were a little hesitant on the press release wasn't because we don't like to be in the news once in a while for positive things. I just think the better story is when these dollars from 2019 flow into the community and they're tangible for people in sort of, a way that could be understood in mainstream media, that feels like a better story. And that's kind of where we were trying to weigh in on that.
Dan, this is Linda. And as the council knows, we're going to be working with legislators to get the reauthorization of 648 and remove the sunset on it. In your opinion, is this a strong example of why our unique model needs to continue and why the reauthorization of 648 is so important to us?
I certainly think it's a talking point in there, right? I know a lot of that is really enabling legislation to allow us to work together in really unique ways around one regional health improvement plan and one model and one efficient way of thinking about community health. So I certainly think it's a data point.
Great, thanks.
Yeah.
Hey guys, sorry, now that I'm on video, can I just kind of circle back just a little bit on, so Justin, if you are gonna, and if Pacific Source team is gonna be meeting to kind of go over some stuff about the nuances or whatever have you, kind of to get to the certain key points of what made the SERP, being ahead of budget to going below budget, whatever the high points of those are, is there a place where we can just circle back and to make sure that we then start tracking it or something? I'm just trying to think of what should be kind of a follow-up of that.
I guess I would ask the finance committee that, and it's not a committee that I go to.
Right, and that's, I just want to make sure that there's some place where.
I think that's the purpose of the finance committee. So I guess I would maybe ask a finance committee chair or co-chair member to answer that. Is there something we're not covering there that is creating a gap in knowledge or a feeling that there's a gap in transparency here? The purpose for the finance committee is partially that.
I think the finance committee is good. I mean, we've gone through this there was some really good work on the Pacific Source team to help reflect these things that Justin, you're asking for. But I think it's sounding like you really want to understand it yourself as well. And so I think it probably would be sharing some of what has already been shared with the Finance Committee with your team. And certainly if there's interest for the full board to have one of the team members go over some of those high level impact areas, that could be a topic for the full board if there was interest too.
Yeah, and you know, I would say I don't think that there's any concern about transparency. I don't think that's the issue. It is just about understanding and maybe then tracking of some of those things that, you know, whatever it was, if there are key big things that cause that, then how are we correcting it, and then how are we tracking it? And I think just clarity around that might be something that's helpful for us. And whether that is created as a dashboard in the Finance Committee, and I know we have dashboards there, but even within those, I'm not sure if we're able to, if we've made the link to what caused us from going pretty high to pretty low and falling behind. And if there's some clarity on that and what the correction plan is, so that that's what we are tracking, and then that's something that's also shared at the board level. I don't know.
I think that would go back to the Finance Committee to Divya. So maybe we could, Donna, have that kind of connect again on this particular topic with the Pacific Source team with these questions from Divya. And then again, Justin, if there's some interest in you having some time to understand it as well, it sounds like I'm happy to have that happen. And then for the full board, we're very comfortable bringing the information back to the full board if there's interest beyond Justin to get into some of those details.
Yeah, I know our team
I
would
would
be
just
happy
add-
to do that. We got a lot of folks that like talking about that stuff. So, and any level of detail. So we'll definitely cause that to happen. In terms of kind of picking a forum for that, maybe I would look to either Finance Committee chairs or Rick, your guidance, or truly whether we want to just kind of take that offline, and any interested party will do a road show, you know, one-on-one kind of offline. So we could go either direction. We just look for maybe a little direction from the group here.
Maybe just a process improvement recommendation or something that, you know, might be more beneficial in the future. I would love the retrospective on what caused this, like Divya was saying, and, you know, what's different from one year to the other. And I think you called out several of them. Fixed payments is probably absolutely interrelated with no adjustments for utilization. So, but I just think maybe it's transparent to everyone on the Finance Committee, but for my practitioners who are participants in the contract, you know, this is how we ended the year, and now Pacific Source has done this wonderful thing for everyone. I didn't see that coming. So I think, you know, the frontline practitioner who participates in this, where if they're more bought into the financial performance throughout the year, there might be more focus on shared savings or other things that we could do. Maybe this group, it's incumbent upon, since we are in charge of the contract. I think I'd love to know that it's going to happen before it does, instead of that it happened months ago.
Well, and Justin, I think that, you know, last year we agreed on the budget didn't get us to 2%. So, and I think that's where the CUS group is really critical in identifying those things that are actionable for us to have an impact on that total cost of care. I think there also were some things that are unactionable that happened to us. And I know that there's still really good work happening with the CUS, but one of the things that we identified, it's not like quick work, like right away you're going to change that total cost of care. But there is really good traction right now happening in a couple key areas that we can, as a provider network, really influence. But then I'm hearing it's also important to understand where are those risks of things that are out of our control that can come at us that we need to be aware of and tracking.
So I think the forum for the this in-depth is in the Finance Committee. And if we need to have a bit more time than the 1 hour slotted to go over this in some in-depth, I would encourage that, Megan. And I think that Cuss is right for talking about long-term trends, but hopefully 2020 was not a long-term trend. So I would think that the forum for really digging into that is the Finance Committee, and then reporting a summary back to the board on that would be the process that I would encourage.
Rick, I would second that. From a governance perspective, one of the things that we will be evaluating ourselves on is how, if our primary role is to oversee and be aware of what's happening with the CCO and in the community where we're over budget, what are the trends that are making us be over or under? I think sharing that with the whole board keeps us informed of it. So we'll be informed and know what direction policy changes we might need to make. But if that work is buried in a committee and doesn't come back to the whole board, and people who aren't on that committee aren't aware, and we're not empowered to make more informed decisions. I think it's a good practice to have the issues or the summary or the conclusions come back to the board for our own education.
Yeah. So Megan, are you okay with that?
Yep, I will chat with my much more talented partner, Chair, Jenny Lender, and then we'll work with Donna and have that be a topic at the next meeting, and then we can bring it back to the next, make sure we have time so we can talk about it at the next Health Council meeting.
Right. Okay, thank you. I do want to acknowledge Commissioner Similik is with us with one of the backgrounds that I've seen on Zoom. So good job on your background. Go Ducks.
Rick, real quick, can we also acknowledge our newest person on the call who's just joined from a phone? Can you introduce yourself, please?
Seth Crawford.
Hi, Judge Crawford. Thank you for joining us.
For sure.
Thank you for joining us, Commissioner Crawford. So any other questions about the JMA settlement and what Dan had announced? Okay, Linda Johnson, you are on about bylaws.
Yes, and hopefully this is the last week for a while that we'll have to talk about bylaws, the last month. The boards have been very patient as the governance committee has gone through a review of our bylaws in light of where we are as an organization and our revised purpose statement. And we've talked with you at a couple of key points, most recently, I think 2 months ago, about a number of key issues as they have come up and gotten the board's direction on it. So the version that you see in front of you today, we are ready to ask for approval and adoption. And as an FYI, approval and adoption to any changes in the bylaws requires a vote of 3/4 of the directors, which we have more than 3/4 in attendance today. So Kelsey, as we're voting, as we're counting votes, it passes when 3/4 of the people here today vote positively. Just a couple of items that we want to get back to you on since the last board meeting. The one question that we had that we've discussed pretty thoroughly is the issue of when an entity, for example, the county commissioners, if they decide they want to delegate attendance at the meeting to the health department director, for example, those delegation of authority issues will be moved to the policy book. You don't see those in the bylaws. Secondly, at our last meeting, we had, in a version, we had mentioned Klamath County is one of the ones currently on the board. And we have removed any mention of Klamath County. The other thing that the bylaws do that was not done at the last board meeting was that we are separating the board's functions from the staff function. and consistent with the governance model that we're moving towards, the board retains authority and then delegates most of that to the executive director. And that how that happens will show up with more detail in the policy book. But with that delegation, we don't need to have a role as treasurer or secretary, because those are functions that the executive director can make sure happens. And we have a committee structure that supports that so that the board is aware and informed. The other major discussion this council had 2 months ago was whether we wanted to list the board composition in section 3.3, as well as who the entities that the appointed directors were from, the organizations they represented. And based on the board's feedback, both sections remain in the bylaws version that we are asking for approval this time. It clarifies, the new version clarifies that the only two officers of the board are the chair and vice chair. And it clarifies meeting quorums and votes to approve for the committees and updates the names on the committees. So at this point, I think that, I also need to mention that at the last meeting, we did not have a quorum. So what I'm bringing to you is not an approved governance committee document, but in the discussions we have along the way, I'm quite confident that the committee, had we had a quorum, would have approved it. And so those who weren't at the meeting, if you have any concerns, I guess now would be the time to speak those up during the discussion before adoption. And I think we're open for any questions.
I wasn't able to make the last committee meeting and I have no concerns.
Any other questions from the board? So, Linda, are we ready to adopt?
Yes, I think we are. So we'll need a motion and a second.
So may I hear a motion from the board to adopt? So I'm going to threaten you guys, because if we don't adopt, I'm going to have this on the agenda forever. So you can either make a motion or I will carry out my threats.
I'll make a motion.
I'll second this, Gary Allen.
Okay, we have a motion and a second. All in favor, say aye.
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 All opposed? Okay, it passes. Good job, Governance Committee. I know this is not always the most exciting piece of work to do on a board, but we really did need a revamp of how we do business, and this was a very good revamp. So thank you very much. I very, very much appreciate it. Hard work to do, so good job.
Thank you. And just to let the board know, we started putting together our work plan for the next year. And we move immediately into the policy book. You may be hearing and be sought for input over the next, I think 3 months is when we perceive that work to be done. And in the work plan for the coming year, we envision an assessment of how the board thinks we're doing in our work and identifying maybe an educational program that would happen at our retreat.
Okay, thank you. Ms. Neugebauer, we are ready for you.
Hey there. Actually, I see Gwen and I meant to reach out to you, but I need to share, if it's okay, my screen, because I made some updates, of course. This is so typical me. I was really excited to meet the deadline of the packet, and then I made some changes. So just minor, and I'll point those out here. So you have seen this many times, usually quarterly for myself to give some updates. This is the third year that we have presented some annual CCO objectives and performance metrics in response to really the work that we're doing with our governing council, which is you all. So this is a draft for 2021. And you'll get the Q4 last update from 2020, I think in March. I believe we have it on some sort of cadence that Kelsey's all over. So I just show up when she asks. So this is a draft that Dan and I created. There are some changes, not really major changes, and they're really just in response to some differences in our 2021 CCO contract versus our 2020 contract, and some additional requirements, and also just some things that we thought we could refine here and make sure that you're not getting duplicative information in various forums. So I'll just walk through these briefly, and please feel free to either interrupt or ask questions, however you would prefer. So this should look familiar. It's the same format. It's the same kind of quadrants here and topics. So in the top left under quality and member experience, none of this has changed. So quality incentive measures, performance improvement plans, and the transformation and quality strategy are all items that we're really working on very regularly, as you know, and so nothing, no suggested changes in this box, and also no suggested changes to the metrics as well. You'll see when if you haven't seen a quarterly update in a while, just as a reminder, I'll just give either a narrative or certainly a quantitative update when possible. So then skipping down to the bottom left box under CCO 2.0 requirements, this probably got the biggest overhaul. And this is again, just in response to the changes in our annual contract with the Oregon Health Authority. So some of these are similar, some of them are kind of moving us down the road in our 5-year contract. So the first one is around value-based payment and that roadmap. It's a 5-year roadmap. We're in year 2 here. And so this was in the 2020 objectives, if you recall, but there are some of the metrics are very similar, but I'll just walk through them briefly. There is a requirement in our CCO contract around our performance around how much of our payments, a percentage of our payments that are in our revenue that are in a value-based payment arrangement. The target at the end of the 5-year contract with the Oregon Health Authority is 70%. We are sitting, I haven't looked at the numbers lately, but it's somewhere in the 60-ish% region. So we have some plans to move that up over the years and to also change some of the arrangements so that we can meet kind of higher value-based payment categories, if you will. I'll try not to go into detail and into the weeds here, but I'll give an update on that quarterly, of course. And then there are some additional requirements that the OHA has come out with around what they're calling meaningful downside risk. Again, there's a lot of detail here, but I will give, I'll try to be very succinct in my summaries around what those requirements are, and really for your knowledge of are we meeting them or not. Right now, I think we have some appropriate questions about our current arrangements and if they really kind of meet that definition of meaningful downside risk. And so I'll be giving quarterly updates around where we stand there. So we have a lot of internal work going on in this space. And then the last metric under the VBP roadmap, you may recall that our CCO 2.0 requirements include what they were calling, the OHA was calling new or expanded value-based payments. In the Central Oregon region, we have quite a few value-based payments. We're in some ways really ahead of other CCOs as far as developing value-based payments, implementing them, and having them across a wide sector. The OHA is asking for all CCOs to expand or to create new value-based payments in certain care delivery areas. And those include behavioral health, hospital systems, children's care, oral health care, and maternity care. And they have them cascaded kind of year over year so that you implement a couple, then you implement, and by the end of the year, or by the end of the 5-year contract, we've implemented all value-based payments in those care delivery areas. We already have met these requirements for 2022. This actually, and then there were some deliverables that were pushed out because of COVID, and this was one of them. So the first 3 that we need to implement all CCOs are behavioral health, hospital, and maternity requirements. Well, we have already fulfilled the behavioral health and hospital requirements with a value-based payment for Sageview, the inpatient psychiatric unit here. And so the last one that we need to implement, which will be 1/1 of 2022, will be in development in 2021, will be in maternity care. So just kind of striking up those conversations now. We have some ideas, and so more to come in that space. So that's the value-based payment roadmap and those handful of metrics in there. We also have a roadmap that you've heard at this group around health information technology. And so there are quite a few things listed here, excuse me, around some oversight bodies that we need to develop, some very specific items that we need to make sure that we're adopting in the community. And we have this all really planned out in a thoughtful roadmap, and some internal subject matter experts and Donna and others in the Central Oregon HIE group are working hard on these items as well. So just wanting to keep this kind of front and center. The health information technology roadmap was largely a development year for 2020, and now we're moving into implementation in 2021, which is why this was added for kind of more visibility here. Number 3 is a new funding stream for 2021. So this is it's called the SHARE initiative, and the SHARE stands for Supporting Health for All Through Reinvestment. This is an initiative in CCO 2.0 requirements that is requiring all CCOs to invest a portion of their profits back into the communities, and there's some specific requirements around addressing health inequities, social determinants of health, aligning with your regional health improvement plan, and designating a role for our community advisory council. So we're suspecting this is going to look a little bit like the community benefit initiatives that the CAC was really involved in 2020. There's some more to come. We're really having to kind of crank out the math and do the algorithm, make sure that we're doing the algorithm correct from the state before we can kind of move forward with what the 2021 plans look like. But we do have a deadline here. You can see in the metric that a spending plan is due to the Oregon Health Authority in June of this year. And so we plan to work really closely with the Community Advisory Council and the folks at the COHC staff to make sure that we are meeting the requirements and also making sure that we're adequately supporting the CAC in these decisions. So much more to come on that, and wanted to keep it on this radar. The last portion in this quadrant, or the last metric here, is really around, we call them the plans. There are so many plans that we have to have for CCO 2.0. And so I've listed most of them here. So health equity, workforce, traditional health workers, behavioral health. This group has seen portions of all of these. Really, this is, again, many of these plans were in development phases in 2020 and are moving into implementation in 2021. And so wanting to give you kind of high level quarterly updates around the implementation of all these plans. I imagine when giving quarterly updates, there might be one, depending on when deliverable deadlines are throughout the year. There might be one that I highlight or one or two that I highlight depending on where the work is in that time of the year. So there's so much, and I didn't want to, I wasn't sure about, there's lots of ways I could have formatted this, but my thought was, again, we're trying to keep this high level. We're just trying to make sure that we hit the high points here and not get in the weeds too much. And so I know that this group, again, has some information around all of these things that you've seen here, and some more than others. And so we're just wanting to kind of hit that sweet spot of elevating it and having some visibility with this group, but also not getting into the weeds. I'm just going to pause there and see if anyone has questions about the left side of the metrics here.
And Leslie,
this is Seth. Oh, sorry. Go ahead.
Go ahead, Seth. Go right ahead.
Are these the metrics that I apologize? I've missed a few meetings, so probably should know this. But are these the metrics that will help us to get at the end of the year, get all of our whatever our requirements done, or are these separate metrics?
So that's what we arranged with the DCO. This is not the performance metrics of the state. But what we wanted to be able to do as a governing board is, well, is the CCO performing to expectations or not? And so what we've done is asked for a quarterly report on some key areas that are high level, but if things are, but they give you a sense about whether things are going well or they're veering off track. And from these, you can ask further questions, and dive a little deeper. So this is just the relationship between the CCO, which does operations, and this board, which is the governing council. So that's sort of the context that Leslie is presenting. And my feedback to Leslie is that I think you've hit a really nice sweet spot. I think if there are questions that board members have, they can reach out to you or some other format to deep dive into these things or deeper dive, but that you're presenting the general information. So
Okay, great.
Does that answer your question, Commissioner Crawford?
Yeah, it does. But are we pursuing the those more specific metrics that decide at the end of the year if we've done our job or not?
Yeah. So the state has, and correct me, Leslie and Dan, if I misspeak, but for 2020, the state suspended the performance metrics and is paying those out due to the COVID crisis. But I believe, Leslie, 2021, are those back in play or not?
They are. So just to wrap up on 2020, so quarter one was kind of business as usual, right? So that was still the withhold. So we will receive whatever performance funds we have based on quarter one of 2020. We'll receive those in July of this year. So there's still that that we're looking ahead for. The second quarter of the year was they were considered early release funds, and so those were expended to the community, as you know, through the Health Council. And then the last two quarters of 2020 were those suspended withhold. So just some nomenclature differences there, but the last three quarters of the year have already been paid out for 2020 performance metrics. 2021, they've started anew. There are some differing improvement targets, lots of discussion at the state level. You can imagine lots of folks still concerned appropriately about where we will be able to perform, as a state, really, and certainly as regions. And the metrics and scoring and other folks at the OHA level have said, obviously they are well aware and understand, and that they will be regularly kind of reviewing and assessing what's happening. And there are 6 indicators that they're going to look at, things like, the governor's state of emergency, the metric around cases per 100,000, et cetera, et cetera. So there are lots of metrics that they're looking at to inform the 2021 quality incentive measure program.
But if I wasn't mistaken, last time it was a lack of information that we were receiving from Pacific Source in St. Charles that was stopping that. And I understand that things are totally different. But are we working towards getting more information about the specific metrics?
Yeah, so I think there's still discussion. So there is, through the Ops Council, there's a meeting where we deep dive into the Quinn metrics. And so it's a lovely meeting of true data geeks, and I totally enjoy it. And the problem when you look at your data is so many of the metrics are so obviously skewed because of COVID, both good or bad. And so ED emergency department utilization has been down. Is that because of our wonderful actions, or is that because of COVID? Probably COVID, unfortunately. Childhood immunizations are down, which is not a good thing. Probably not going to be able to impact that until the COVID is managed better. So there's just, there's hardly a metric in there that isn't totally skewed for good or bad because of the COVID crisis. So that's the debate that's happening at the state level, is trying to sort that out. And
Yeah, no,
Leslie-
I totally agree. Oh, sorry, go ahead.
Go ahead, Seth.
I just want to say I totally agree. But what, you know, during this time when we're trying to figure it out, maybe we could start working on a system where that committee reports to the larger committee, and then we can have those conversations.
Okay.
Every meeting, or maybe it's not every meeting, maybe that's too often. But if we had like a 15-minute report from that committee to help people understand, and then if there was issues, clearly right now there's going to be issues that we can't control. But as we move forward and move through the COVID ordeal, then, you know, things start leveling out, and then we can start having those conversations. And if there is something weird happening the second month of the year, instead of waiting until the end of the year to say, oh, yeah, we blew it, we could have those conversations early and have a meeting with all the people at the table and say, what can we do to fix that?
Okay, that makes some sense. Leslie, oh, go ahead, Divya.
Sorry, I was just going to add just a little bit, and I don't know if this will be helpful or not, but I just wanted to update you guys or inform you guys that I was appointed just recently, I learned, by the governor to sit on the state's Medicaid Advisory Committee for the next 2 years. So for whatever it's worth, I mean, I don't know what that, kind of where that's going to go in terms of influence and things like that, but it's certainly, I'm happy to share whatever updates I can bring to this group too from that standpoint, and also convey our concerns.
So thank you. That is always good to send that in. Dan, you took yourself off mute and I was headed toward Leslie. So I'll start with you.
I was just going to convey my congratulations to Divya for that esteemed honor.
Well, we'll see how that goes. Thanks.
It's a lot easier to be on those committees if it's all on Zoom than driving to Salem all the time, believe you me. Leslie.
I was going to also add, and not to put Iman on the spot in her first meeting, but it's my understanding that she is also part of Metrics and Scoring Committee at the state level, which impact the quality incentive measures. So between Divya and Iman, we have and actually so is Charity from Advantage Dental is also in Metrics and Scoring for the oral health seat. So we have a lot of really great opportunities regionally to impact some state level policy.
So it may be what I'm hearing from Commissioner Crawford. And so I'm looking to you, Leslie, to think about this in a practical manner. Is potentially a quarterly report on performance on QIMS, which you do have in here. And I'm sort of, again, wondering whether it, so give some thought about what it would look like, because I know the reports that we go through are all incredibly alarming early in the year. And then they look a lot better at the end of the year. And that's just the nature of that data. So don't want to artificially freak out the board unless you're like wallowing in that data on a routine basis. And then it may also be to some advantage for Iman to give us just a real brief summary on a quarterly basis about the debates and discussions on that committee. I know they can be incredibly obscure, but it, if you can find a way of bringing those back up to sort of general language, that may be a great way to just to see where the discussions are going at the state level. And Juan says, happy to do this. So give some thought, Leslie, about practical ways that, those of us on Ops Committee have had to learn over the years what the patterns look like. And I certainly spent a couple of years freaking out early in the year and then realizing that that was just normal.
Yeah. Okay. Okay. Happy to.
Could you add the historic rates so it gave context to why it was at where it was? And
yeah, they do that actually.
Something along those lines.
Cool. They graph it year after year, and so they have these graphs going, and so you can see what your pattern looks like compared to the year before, and that's super helpful. So, and that may be just sort of the level. I don't know. So give some thought and give us back a proposal.
We'll follow up.
Yeah, I don't want to. Okay. Thank you. Financial stability, I think you're at.
Sure. I'm going to move on. So top right, financial stability. These are relatively the same. So again, the overall objective is around really maintaining a stable financial position. So, and making sure that any cost of care targets we may have are right on par. So not wanting to duplicate on the QIM piece, which, is similar but different. So there is, well, anyway, so we last year had 4 metrics here. There are 3. They are, you've seen these before from 2020. The one that I suggested taking out was ED utilization. So the first one here is ED utilization among members with mental illness. The other was just kind of overall ED utilization. The reason that I suggested we take it out was a couple of reasons. One, that it's not being tracked at the state level. It hasn't been a QIM for a couple of years. It's not in our shared risk arrangement metrics. And because the last time that we were rigorously tracking this before the state really took it off their radar, we had one of the lowest rates in the state. So I understand it's a potentially financial indicator, and obviously this doesn't really have anything to do with 2020, but certainly that was a historic year for many reasons, but specific to utilization. So that was the only suggested change in that box. And I'm just going to pause there and see if anyone wants to say anything about that box.
So Leslie, maybe this is a discussion to take to CUSP, but both, I know from our work that both ED and hospital readmissions per year is pretty highly correlated to behavioral health reasons, and probably is a place that one could reduce costs if we could figure that out better. So that would be a CUSP question, not a full board question. So just noting that.
And another reason why I kept the first metric in, because I think that's important as well. Okay. I know a lot of work is being done, and we're talking about CUSC, of course, and a lot of work is being done at Finance Committee. So I'm sure there's a lot more to come here. Okay, so bottom right on CCO operations, I did make, these were the last minute changes I made, just based on some conversation with my colleagues. So this first one is around performance against any OHA performance standards. So we have an annual audit call. It's historically been called the external quality review. Now we have more of a kind of rolling review process where they're calling it the external quality activities. And so they're looking, many years previous and some corrective action plans that we may have been on. And then of course doing our annual audits still, and anything else that might come up ad hoc outside of that kind of annual review. So those are kind of continuous things that we're always working on with the Oregon Health Authority. And so making sure that we are meeting those performance standards, and wanting, of course, to raise that here if there's anything that is problematic or concerning. So that one is the same as last year. These last two, so the two that used to be on here in 2020 were around call service levels and claims payment turnaround. And the reason I suggested taking those off was because you already see that often in the dashboard that's further down in your packet. So that's a monthly dashboard. It is not on there every single month. We usually do it quarterly, but my thought was not to try and duplicate and also to add some more meaningful metrics here. So that was my suggestion. And then the suggestion to add instead of those two was really looking around, it kind of falls into this 2.0 requirements around the plans, but really looking into access to care and some increased monitoring that we're required to do at the state level, and some metrics there around, first really developing this work. So establishing a measure set and identifying a baseline. And then we are planning to launch a new member access to care survey. And so bringing that information here. This has been something that I've been really interested in for many, many years. So super, sometimes things have to become a requirement in order for things to move. And so I'm really pleased that this work is occurring. I think it's really important. So access to care is number two. Number three is around the health equity plan, but more on the operations side because this is really looking specifically into our grievances and appeals processes and operations. So specifically, and there's a specific call out, around underrepresented populations. So specifically, we are developing some recording capabilities internally to be able to look at our grievance and appeals data specific to race, ethnicity, language, and disability. That's something we've also been really interested in doing for quite some time. So I'm pleased that we're looking forward to this in 2021. Additional metric there is around then once having that information, comparing our general population from our grievances and appeals to the kind of real D population, and really looking at any, establishing a baseline first, and then really looking at any potential process improvements. And then also really looking into utilization of grievances and appeals, which historically are pretty low. So those are my suggested changes. I'm not sure if anyone had a chance to look. Maybe this is good that if you didn't, that this is my suggested draft for the 2021 objectives and performance metrics, and happy to take any questions and or suggested edits.
So any questions or feedback on these metrics from the board?
Let's see, what's the timeline? Maybe I missed it for launching the new member access to care survey. And does that include across all, well, it does include the dental as well.
It does. I believe that, I actually believe that we're already trying to do something now, but I don't have that information right now. I know that this has been talked about quite a bit internally, and so I'm happy to get that information and let you know, but it will be across all care delivery areas.
Anyone else? I would just observe that from my point of view, real healthcare reforms occurs in just what Leslie's doing. It's not the big bold stuff and the sexy stuff that gets a headline. It's these detail grinding things that real work is happening. And I just reflect on how much the environment and the conversation has changed over the years, and it's due to the backup and the detail that is happening that this little page represents just a boatload of hard work. And so really, really appreciate that hard work and just know, Leslie, that the real work of healthcare reform, you're really doing it. You know, you're really doing it, and it's hard work, and it's not sexy, and it's not groovy, but this is how you do it. So thank you.
Well, thank you, Rick. And please don't forget that there are literally hundreds of people doing this work. I'm just the messenger.
You're no, it's all you, Leslie. It's all.
Yeah, of course.
Yes.
I have nothing else to do. Okay, thanks for letting me take over, Gwen and team.
Okay. The next piece is Gretchen, you're doing CCO 2.0 workforce development.
I am.
Hey, Rick.
Yes, Dan.
Sorry to interrupt. And I'm looking at the screen and not the board packet, so forgive me. Did we? Does that item need, as Leslie mentioned, this will be the third year that the CCO has proposed with, I think, board approval or endorsement of those as our annual objectives.
Oh.
So do we need a motion to approve that? Because that's going to become that becomes our 2021 CCO governing, main set of metrics and objectives.
Good.
Point.
Good catch.
Good call, Dan. Yeah.
Thank you. So given that, Leslie's proposed, and I think she's made some nice changes to those. And again, these are metrics that Pacific Source, as the operational component of the CCO, is presenting to the board to allow us to do our governance due diligence about is the CCO performing or not. So that's what we're trying to do here, and this is built into the arrangement. And so what we're looking for is board approval that these are in fact the metrics that we will be using this year to judge performance. Did I capture that correctly, Dan?
Yeah, I honestly can't remember, Leslie, maybe you did, but it does feel like we did a level of endorsement on those in past years. I did note it was listed as just information for today. There's no reason that the board couldn't say, this is a great first bounce. We want to have some further discussion and maybe have this on as an approval item in February. Nothing bad's going to happen if we want to just have more discussion and consider this a first bounce. But I know Leslie and I both think it's a good idea to have these endorsed, because this becomes a pretty important governing tool as we move forward in the year.
Totally makes sense. Brad, you took yourself off mute. Did you have something?
Yeah, thanks, Rick. I just have a question, and maybe it's buried underneath these very concise titles and metrics. But there is a health equity plan that Pacific Source just finalized, and so I see a metric to develop that plan, but I'm wondering, is there a metric within all of these metrics on this page that tracks, the quality of member experience is what I'm focused on, of the most underserved, groups of folks in our, or highest risk folks in our communities.
That I can just speak to that. That's something that I'm also very interested in. I think that we are getting there. The access to care and the looking at the grievance and appeal data, I think, is the first step of that. I really want to say that I think that's right for a 2022 objective, with some development in this year.
Okay, so it's not currently included, but there's a plan to include it.
Well, there's so much work going on. It's just not right.
Okay.
Yeah, I would say.
Thanks.
Okay, so what I would be looking for is a motion from the board to support and adopt these as metrics that we will be using with CCO to monitor performance.
I would move that we approve the document presented with the addition of the Access to Care Survey and the Health Equity Plan.
Do I have a second?
I'll second.
Okay, great. Any other discussion? All in favor, say aye.
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 Opposed?
Hey,
Just,
Rick, I think just for purposes of, I kind of have this dual role where I'm serve on the board, but I'm rep of the CCO as well. I'll just abstain because I think that's probably the best position for me on this one.
okay,
I don't know if it really matters, but
that's fine. That
I'll
makes,
abstain since it's us. It's me monitoring us.
right. And my interpretation is Justin did a nay. Okay.
Hey, Rick, it's Iman. Where, as a new member, I'm curious, where do these documents live? Are they sent out in the packet and I'm missing them? Or where can we see the plans and then specifically the document that Leslie presented?
That was in the board document, the board packet, and it is right after the bylaws. So page 16 on the packet that Donna presented.
Leslie, is that the most current one?
Then Leslie updated it, and then that's what she presented, and the changes were under CCO operations.
I will send them to Donna and Kelsey now. I'm drafting it now, and then they can send it out.
Okay, thank you.
We do have a request from Brad about asking Justin to explain the nay vote. Not required, Justin, but maybe we do have a.
Sorry, I didn't hear that one.
Oh, so I have a request. Sorry, I was talking too softly. I have a request from Brad wondering about your nay vote.
Like you want an explanation for why I didn't vote yes?
Yeah, this is Brad, only if appropriate. I mean, it's learning. To me, it's learning. I mean, you must
Sure.
have a reason and it must be important.
Well, I just think everybody who's kind of had to listen to me for a couple of years now has heard. I think my company looks at value-based care very differently than our community does, and I think that the contract really disincentivizes proactive panel management. It effectively, with a capitated rate, allows the urgent care to, or I'm sorry, the emergency room to be used as a de facto primary care clinic. And I think there's some serious flaws. I think this year and the budget demonstrates, I think, some of the serious flaws of the contract design. So I can't in good conscience say that these metrics represent the next level of value-based care when they're really just they're really just an expansion of the current contract. So to me, my vote against it, everybody's heard it enough times. That's why I don't think there was any point in getting into the conversation. I just think in the long run, truly bending the total cost of care means high cost centers can't be utilized as, outpatient service groups. So emergency rooms should be for emergencies, and readmissions should be tracked for readmissions. And a lot of the things that really are part of the fundamental block and tackle of primary care have to be embraced if we want to bend the cost curve. And I don't think a lot of that happens here, especially removing the ER metric. Yeah, the rates are low, but comparative to what? So the rest of the groups in this category, maybe other contracts, the rates aren't that low compared to other population groups. So I think a lot of my no vote there also is that things show up. There's very little actual debate on these things or discussion of true numbers. So I don't know that those metrics are proven out to do much of anything to bend the total cost curve. And it certainly isn't in a fixed contract where a large portion of the money is paid out regardless of performance. So in general, that's my.
I appreciate that, Justin. Yeah, I mean, I'm not embedded in the healthcare system, and I'm new to the Health Council, and I guess I would ask whether this is the appropriate time or not. Is there any effort on the Health Council to address the issues Justin just raised.
Yeah, there is a lot of work being done around that and a lot of discussion. I don't think we're in agreement about redesigning the fundamentals of the contract. But I think there is a lot of interest in trying to find within the construct of the current contract to do a better job about reducing our the drivers of our expenses and the healthcare inflation that we have. So,
and Rick, I might add, I think I see the document that we're agreeing is more of a oversight document of the responsibility of the governing board with the CCO, and it's more than just and it's not the contract elements that are negotiated between providers. And so I see like there's different components of this that are really unrelated to actually what the details of the contract negotiations are. And this is more of a document that was created to help us from an oversight perspective to have 4 categories of metrics to assure that we're working together with our CCO partners and accountabilities, because they also have an accountability back to the state. I think that what I also see in the work of the providers in the contract negotiations, I do see a lot of alignment around the interest in reducing total cost of care, and there's different ways to incentivize that happening, and those discussions happen at that contract negotiation level, and learning over time like what are the best ways to create a contract that does incentivize us moving down the road of high quality care at the lowest cost. So that's just my perspective of what I've seen over time. But I see this as more of a governance document, not really specific to the Medicaid contract and the elements within it.
correct.
Just again, highlighting, working for a company that does this, and it's in every contract that they have, your governance, your alignment, your incentives, all of it should be perfectly aligned if you want to have a value-based contract. So having something where, you have targets that don't have proven outcomes, that don't align the provider metrics, but they're overarching targets, is a problem. You want the metrics that you're focusing on that say that are a success to be proven that they'll bend the cost curve, and then to be incentivized through the contract. And if you have that pure alignment, that's where you get performance. So I think that actually highlights really well another reason for voting against it.
And I think the other thing too, Justin, that's a little bit different is that there are state requirements like the technology roadmap and those kinds of things that the CCO is accountable to delivering to the state. And so having some of that in here keeps us all aligned around those areas that we do need the CCO to deliver on. So
no argument.
That's a little different, than other peers.
No argument there. Absolutely.
Hey, thanks, Brad. You really opened up a mess here, can of worms. It's all your fault. No, good question, actually. Very good question. So, Gretchen, we're back to you again. And this is something I'm interested in because in my field, it's increasingly difficult to find staff.
Well, I appreciate the opportunity. I'm going to skip some slides here to try and come in around 11 minutes from now. I know that you have other business today, but you've got this in your packet, and I presented to the PEP yesterday with more detailed information. And I hope maybe I could come back and we could do some brainstorming together, future state. So I'm here to talk today about provider workforce development as it relates to our CCO 2.0 contract. And just quickly, I want to provide awareness of what our requirements are, talk through our regional assessments. I'm going to give you a preview of some strategies and then walk through next steps. So I'm going to skip this slide. The main thing to know about the changes in the 2021 contract as it relates to provider workforce development is the due date, A. This was pushed out. We never turned anything in 2020 because the state pushed it out. now due in 2021, and that is both an assessment of our members and our providers based on their demographics and capacity, and then action plans, right, strategies to address any gaps that we're seeing. And provider workforce development in the CCO contract has a focus on the delivery of culturally and linguistically appropriate and trauma-informed care. And so there's a lot of overlap with our health equity work and a lot of emphasis on things like interpretation services and traditional health workers. I'll be talking about that more. For those of you who are familiar with state reporting, this information now all rolls up into our delivery service network called the DSN Narrative Report, which is annual. So it's not a standalone report like the health equity plan is. It's a plan that gets rolled up into another document now. So those are the main changes for 2021. I'm going to skip that slide. I'm going to skip just quickly data assessments. We pull from state information, which is required. We look at our own claims and capacity data. We look at member demographic information, and we rely heavily on the Oregon's licensed healthcare workforce report. That's an area of focus because we are still trying to figure out the best ways to capture provider real D data. So I'll be talking more about that. So I'm jumping right into provider assessments. So in Central Oregon, we have an adequate provider network for physical, oral, and behavioral health needs. We are struggling to get some traditional health worker pieces built in, particularly birth doulas and patient or personal health navigators. The two reasons for that are birth doulas tend to operate independently, always have, haven't been contracted with health plans in the past. We have no billing codes for patient or personal health navigators, and there's no approved training. So these are gaps that have long-term solutions that are needed. We also know that we can anticipate, and we have already seen growth in behavioral health needs based on COVID and membership growth. So we're looking at how do we continue to build our behavioral health network. This is a problem across the country. It's a problem in the state, and it's a problem especially in our rural communities. We're currently meeting our capacity standards based on our monitoring process, and we want to develop some new, more robust monitoring strategies to dig into capacity based on the new requirements, especially for vulnerable populations. And then finally, we're going to refine our provider member ratios. We have a project going on to make sure that we are using evidence to drive those ratios future state. In terms of provider language, race, ethnicity, and gender, based on current data, Spanish is the top non-English language spoken by providers, and we don't have enough Spanish-speaking providers based on our current member language needs. This data, it mainly comes from the state report, and the majority of Oregon combined healthcare workforce is white. The majority of Oregon physicians are white, same with counselors and therapists, and the majority of dentists are white. And provider genders are approximately evenly split, with a slight majority of all provider types being female, especially in the counselors and therapists area. So the data gaps here are our provider demographic data is incomplete or limited, especially provider race and ethnicity data. That's also true for the state's report. We also have an unknown number of providers that have completed culturally and linguistically appropriate trainings, like implicit bias and trauma-informed training. So we'll be doing work around that. We're learning now, we're doing monthly surveys on provider capacity to make sure providers can meet the new requirements, which are very specific, and some of them are very different than what they used to be. We're still gaining more information on the use of healthcare interpreters, both from vendors and in clinical settings where they have a staff person act as an interpreter. And we're still trying to learn more about who's qualified and certified, even though that's a requirement. There are some challenges to collecting that data. So we have a new system in 2021 that we just launched to learn more in that space and ensure compliance. Yes, yeah.
Brad had a question.
Oh, sure. It's hard for me to see when things pop up.
What percentage of providers were included in this assessment? Was this covering all, or was this a survey doing a percentage of
That's a great question. So this language, race, ethnicity, and gender data, this is statewide. We do not have enough comprehensive provider demographic data for our CCO providers to do a demographic assessment. It is very challenging to capture this data. There's also an OHA project underway to collect provider realty data. Right now it's attached to COVID, and we expect this project to grow over time, which will be extremely helpful long-term. I hope I answered the question.
Yeah, thanks. I just have one follow-up. So you said this is statewide?
The provider language, race, ethnicity data is statewide at the moment, yes.
So there's no way to break it down to our region?
They don't do, the state is not doing a complex breakdown right now. So they're just about to release their new report. It was in draft form. So maybe there'll be something new in the assessment of 2020, but they haven't done that in the past.
Okay, I mean, it seems like they could just based
I'm
on
sure we could, right?
zip code or city, you know, whatever. Okay.
Absolutely. And we want to be collecting this data to make sure we're driving strategies. In some ways, it might be better for us to collect this data based on what we know with member realty data and inconsistencies or incompleteness there. We definitely are going to be working to collect more of that through our credentialing process, future state. So in terms of member assessments, this information does come from the realty data of members and is specific to Central Oregon. So the vast majority of Central Oregon members speak English, 94%. Spanish is the top non-English spoken language by Central Oregon members. And 1 in 20 of those members speak Spanish, so about 5%. Jefferson County has the highest proportion of Spanish-speaking members, higher than Crook and Deschutes. And overall, less than 1% of Central Oregon CCO members speak other languages. And in ranked order, those are Vietnamese, Cantonese, Mandarin, Russian, and Korean. These last two pieces are really important. Members who indicate they speak English not well or not well at all represent a small but really important member percentages. In Central Oregon, it's about 1%. But maybe more importantly is that information is unknown, and which means it's not reported by members in about 65% of Central Oregon membership. So we need to do more work here to get this information. And membership is fairly evenly split between male and female. However, we only collect binary gender data, so that represents incomplete data. So there's work to be done there too. Member race ethnicity is also specific to Central Oregon CCO membership. The majority of members who self-report as white is 67%. But the second highest ranking race ethnicity category is unknown, and that's almost 20%. So again, more work to do here. And on average, the third highest ranking race ethnicity category is Hispanic or Latino. That's about 11% or 1 in 10 members in Central Oregon. And I just want to point out that where you see parentheses here, these are the state's categories for race and ethnicity. So we use their categories. More Hispanic members speak Spanish or speak English than Spanish. That's an important thing to understand. And 1 in 5 members identify as Hispanic or Latino in Jefferson County. In Jefferson, about 7% identify as American Indian and Alaskan Native. And then across the region, less than 1% of Central Oregon CCO members identify as either Native Hawaiian or other Pacific Islander, Black or African American or Asian. Just over 1% report some other race. And so data gaps here, as you saw, some of the member demographic data is incomplete. We don't collect non-binary gender data. We don't know much about member healthcare interpretation preference, so we're going to be asking some of those questions in our Medicaid survey to members. We need to learn more about member experience of access to care and quality of healthcare interpretation. That access to care piece will be information that feeds into the metric you just approved that Leslie called out. Our member understanding of and access to traditional health workers is unknown, and our traditional health worker data collection overall is incomplete. We've got inconsistencies, gaps in data, and challenges with, especially in our community-based groups, to collect this information. So I'm at time. So Central Oregon member disease prevalence, I think I'll just focus on this ranking here. Top 5 ranked diagnosed diseases are depression, serious and persistent mental illness, substance use disorder, diabetes, and obesity. So you can see that we have a huge need to ensure that our members have access to behavioral health services. So just the top 5 assessment takeaway with, which is really a strategy overview. We're going to work on improving our member and provider realty data collection, expanding access to BH services, particularly Hispanic, Latino, and Spanish-speaking providers, including traditional health worker types of peer support and peer wellness specialists, identify, develop, and or support provider workforce pipeline projects in collaboration with community partners, develop and implement provider training projects, and identify and implement strategies to improve access to certified traditional health workers and healthcare interpreters. Just wanted to highlight some great things that happened even with COVID in 2020. I'm sure all of you know about the successful OHSU How To Behavioral Health Consortium grant. We endorsed St. Charles Rural Graduate Medical Education grant that Rob Ross advanced. We developed a community health worker online training in collaboration with COCC, and that's the first community health worker training in Central Oregon, and that will launch in fall 2021. In 2020, we expanded access to telehealth in Oregon through our Community Health Excellence Grants Program to the tune of around $1 million. And we provided traditional health worker training grants across regions in the state of Oregon to the tune of $125,000. And for the 2021 Community Health Excellence Grants program, we added a provider workforce development priority area and doubled our funding to try and advance more of those pipeline initiatives to improve recruitment and retention and access. And then finally, we did develop provider education opportunities and materials, and we will continue to do so in 2021, have a very robust training plan that includes complementary CEUs for providers. So what I wanted to talk about, and you can tell me if we have time or not to do this, but last year I asked this, and I want to ask this again, and I want to pick your brains if we have the opportunity about pipeline projects happening that I may not know about, what your pipeline priorities or provider priorities are, and if you have recommendations of who else we can be talking to, I'd really love to hear your thoughts. So Rick, I'll let you tell me what makes sense here given timing.
You got 5 more minutes if you want.
5 more minutes, okay. So I don't know if it's possible based on your current structure, but wanted to ask if adding a provider workforce focus, whether that's committee structure, subcommittee structure, or simply a focus to an existing committee is possible. And really the goal here is to work together to implement a collaborative pipeline project, knowing that it's going to take collaboration to advance these long-term strategies. So I guess that's one thing I see. There's something in the chat.
Right. So Gretchen just made a request for feedback. And can any board members give that feedback about would it be helpful to create a committee structure about provider development and workforce expansion?
Hey, Rick, if no one else is going to speak up, I think Donna knows more about this than me or the COH Health Council staff, but there have been efforts between Pacific Source St. Charles and the East Cascades Works, the Workforce Board, to focus on workforce diversity, specifically in the healthcare field. I don't know where that's at in terms of progress or outcomes or any achievements. Or data gathered. I know that they did start a website. I think it's centraloregoncares.org, if I'm not mistaken. But I think it's kind of a repository of information. I'm not, again, I don't have any updates, but I believe the Health Council might have been also involved in that. I'm not 100% sure. It was St. Charles Workforce Board and Pacific Source for sure.
Yeah, we, excuse me, this is Donna, and we are currently still working in that space. Some of the smaller projects that we've done was we have funded a position at COCC as well to get into the high schools and talk about kiddos moving forward. Gretchen, I think you're aware of that one. We were very instrumental in the how-to grant, actually helped provide the budget. And we continue to work in those varied and sundry pipelines. Thank you for mentioning that, Brad.
Sure. And there's one other idea that I don't know if it's feasible or not, but there is a national like headhunter group, the for-profit, and they charge a pretty hefty sum, but they're specifically focused on hiring for diversity. So they have, they've built up networks over the years. I was actually hired through that. One of their little, almost 15 years ago, one of their little, one of their, I guess they have several pieces, like some are focused on African Americans, some are focused on Latino, and it was called Lat Pro. And that's actually how I found out about my job with Latino Community Association 15 years ago. And so it's just maybe I don't know if there's some way to like centralize a contract with that organization. I mean, of course, first, vet it, figure out if they're effective. My understanding is they're very effective, but kind of centralize, a package for providers to hire, through that system. I don't know, it's just an idea. And I can
Brad, I'd love to chat with you more about that. I haven't heard about that. So thanks for sharing that information.
Okay.
Gary?
Yeah, to address bullet points 2 and 3, I'd like to point out, and I'm sure some are already aware, that Advantage Dental also was awarded a how-to grant and with a focus on training dental assistants where there's a statewide shortage. Actually, there's a national shortage of dental assistants. But dual train them as traditional health workers and embed them into our system. It's not specific to Central Oregon area, but certainly Central Oregon is one of the areas in our footprint that would benefit from it.
And I know our traditional health worker liaison, Tanya, is working, well, all of them are working with our CCOs and DCOs to talk about traditional health workers. And congratulations on that grant, Gary. It's really exciting. We funded a similar grant for Capital, just a one-person integration opportunity, the how-to grants. Very exciting.
Okay, so this is a good discussion. I'm going to cut you off. Move on. So I'm not sure we answered your question. In fact, I know we didn't. Donna, let's just talk about that and be able to try to figure out a process forward about answering that question.
Sounds great. Thank you, everyone. Appreciate the opportunity.
Okay,
hey, Rick, just real quick, is the CO Central Oregon Diversity and Inclusion Work Group addressing that topic at all? Can anybody speak to that on the staff? Or
Ben, please.
Trying to find my unmute button, sorry. It's a need that generally arises. I know we have partners that are working in the coalition that's been previously mentioned, and that's where most of the work is going on.
Okay.
So the Cody is not doing anything directly at this point.
Okay.
Yeah. Okay. It is a need, I can assure you. And also just include rural services. We just have a lot of open positions that I'm struggling to fill in the small counties. Okay, thank you. CUSC, Divya, do you want to talk about that? People may be tired of listening to me. I'm tired of listening to me.
Sure. I think not much to bring in up. Well, I guess that's not true. So CUSC update at the Finance Committee. I think there was a little bit of discussion as to what CUSC's role is going to be in this next year. Where did we kind of land towards the end of last year? And it took a while for CUSC to kind of figure out what they are going to be doing, narrowed down to kind of 3 main areas. And then based on that, I think one of them, which was around cost group, that was Justin and Kim Bangerter from QUIPA and someone from St. Charles, the name is escaping me right now. They were kind of working on this, and I think the thinking behind that was that a bunch of issues that were raised in that area is gonna have to get tackled through the contracting side. And then some of the other issues obviously have kind of percolated up again today for similar reasons, because they are kind of big issues, and we have a little bit of an urgency of getting our arms around that one. And so, you know, whether it has to happen through contracting and some aspects of it, and then what that looks like and what that forward movement looks like, and how that gets tied into the Health Council arm of it is still getting ironed out as to kind of what flows through the finance and things like that. The other 2 groups are orthopedic group. And I can tell you that this morning we had our next meeting of that group. It went really well. We're kind of at a state now where all the data has been reviewed, and we are developing some concrete next steps as to which, within all the data that's been presented in the ortho arena around cost and quality, do we start to do a deeper understanding within, and so that the center can then start to work with their own teams of what metrics they're going to hold themselves to and how they're going to start tracking it. So that's kind of the next state. And so some work is going to come out of that, hopefully in the next month or 2, to start to formalize a plan that they are going to have some focused efforts around. And then the behavioral health side, Rick, I'm going to let you talk to that one.
Sure. So we had a couple of meetings, and so Pacific Source staff, led by Dr. Franz, have developed a fairly detailed action plan that they've actually implemented. I mean, they've broken the culture of Central Oregon. I'm really shocked and worried that they actually went from endless discussions to actually doing something. So they are fairly actively trying to address low value care within the behavioral health panel, which is the part of behavioral health services that has bloomed so much in the last couple of years. And then what Divya and myself as co-chairs are meeting with Leslie and Brian at Pacific Source to get clear about where we're wanting to go in the coming year. And so we have some processes going forward in the subcommittees. The one piece around cost of care has gone to contracting to be sorted out there. And so I think we wanted to have a small meeting to see what was possible and what best processes to go forward with. And that meeting is sometime this month. So any other questions or additions to that?
Rick, this is Linda. I had a question. I know that we've been focused on cost utilization and it feels to me like an internal perspective on how we can integrate more with behavioral health. My question comes for the future, when we recognize community needs for integration of behavioral health and things. For example, I saw a request in the paper from the new Bend Chief of Police that they would like to have more behavioral health providers available to the police and integrated so that when they get calls where they think it might be a behavioral health issue and not a law enforcement issue, that we can be more effective with that. And so my question is just how do we shift? How do we respond to those requests? Is that something we should do through the RIP side of things? Is there another way? Do we have a process to respond to requests?
So, I mean, that specific request really, I will take up as the new police chief being new, but there's a long-standing and very vibrant and very forward developed partnership between Deschutes County Mental Health and the Bend PD, and very outcomes driven. And I have serious envy of that program, and I'm trying to stand up a similar program in Prineville with the Prineville Police. So I don't know if that's really, that specific example is a CCO issue as much as a CMHP issue, and the new police chief not knowing all the cool and groovy things his department's already doing. But I think the cusp is identifying the driving issues. We won't be able to address any upstream issues if we keep having our healthcare inflation go faster than our rates are going up. So that's the issue that if we don't address, then none of those other upstream community needs will have any funding.
Thanks for the clarification.
Yeah. And that's why sort of the internal provider driven, what are we doing performance issues. Any other questions? Good. And then updates on the RIP work groups.
Hi, everyone. For the last few minutes, the project managers are going to share with you what 2020 has held for the RIP work groups and what's ahead for 2021 and the years to come. Hold on here. Let's see. There we go. Find the right button. All right, and my notes. All right, so the RIP, the new RIP cycle started in January of 2020. And the region, which is 3 counties, Confederate Tribes of Warm Springs and Northern Klamath County, approved 6 priority areas. As you can see, each priority area has a wide variety of future state measures, and those future state measures are really our population level metrics. And those future state measures act as our guide to all the work. So these are all available on our very exciting Central Oregon Health Data website. You can see that at the bottom of the slide. So if you want to learn more, that's the place to go. Participation is really active. We have a broad range of numbers of active attendees per each work group, and a really nice growth in partner organizations and diversity in partner organizations involved in each work group. This becomes really important as we're trying to address really systems level change across the region. And this demonstrates also that our job as a health council is to really inclusively convene partners to improve our regional health. And that requires, building relationships, developing that shared vision and shared approach, a shared understanding, developing and using our differentiated personalized approaches and prioritization of equity and inclusion practices. A couple of the tools that we use to do all that, to convene our broad and diverse partners, is the A3 process. We also call it our strategic problem solving tool. And this is our process for building a shared regional understanding of our priorities, our future state measures, root causes, and developing shared actions. For facilitating community development, we use a structured participatory community development methodology. The methodology was developed by the Institute of Cultural Affairs, and it's used worldwide for over 50 years. And they developed a set of tools called Technology of Participation, which you all have experienced with the strategic planning that you did last spring. That methodology is grounded in collaborative strategies that draw upon human assets and build social capital to facilitate sustainable community development. For this RIP cycle, each work group has $2 million to use until the end of the RIP cycle on December 31st of 24. And all the funds are available for the full term of the Regional Health Improvement Plan. And when we say that, we mean that they've been reserved and set aside for this full year cycle. They won't be impacted by any external environmental changes. The funding reports that you receive in your meeting packets reflect this time frame, and that's different than the previous RIP cycle. At the end of this RIP cycle, in the end of 2024, any remaining funds, if there are any, are going to return to the Community Impact Fund and be used for future community investment. We've made this change for this RIP cycle for having full funds available for the full 5-year cycle because we recognize the role that money plays in supporting collective systems level work. Those things take more time to develop relationships, develop a shared approach and strategy around those. So that's a change in the funding that you'll see. Michaela.
Great, so this is the timeline for moving the work groups through the structured problem solving process. In January and February, we spent time onboarding our many new community members and partners, getting them familiar with the RIP culture, culture of the Health Council, and our regional journey in this work together. And in February and March, the work groups developed a shared understanding of the background. Why is this important? The current state and future state measures for each of the RIP priority areas. And then in March, COVID hit our region, as well as the community response to the murders of George Floyd and others. These events caused delays and impacted our work group progress, just as it impacted every other organization. During this time, many of our work group members were pretty checked out and focused on COVID response. So we pivoted and spent a couple of months really trying to meet the needs of the community. We heard from organizations in Central Oregon that were head down focused on COVID response and had minimal communication or coordination between each other. So we gave the work groups an option to use their meeting times to share resources, make announcements, and really coordinate their efforts. And sometimes this took the full meeting. Per the work group's request to address COVID, we rapidly stood up the mini grant process in April, and the mini grants are grants of $5,000 or less. As you can see on the timeline, we originally expected the work groups to decide on their strategies and invest by September. But now with our updated timeline, we're expecting these work groups to make their first investments by Q1 of this year. This work really moves at the pace of the community, and we recognize the ongoing impact and stress of COVID. Next slide. So as I mentioned on the last slide, at the start of April, we quickly stood up that mini grant process, largely in response to COVID. Over the summer, we worked with the work groups, CODI, which is the Central Oregon Diversity, Equity, and Inclusion Committee, and our DEI consultant to really refine this process. And we launched that updated process in October. So the new process includes criteria that emphasizes our desire to support projects that focus on collaboration, capacity building, and equity. As you know, COVID has greatly impacted food insecurity locally and nationally, and it will continue to require collaboration and equity. One of our mini grant success stories that demonstrates this is in 2020, the Double Up Food Bucks program was implemented at the Benton Farmers Market. The Double Up Food Bucks provides additional or $10 additional to SNAP users who choose to redeem their SNAP funding with farm direct purchase at the farmers market. And 172 people self-reported that they were the first-time recipients of the Double Up Food Bucks program. Next slide. So to guide and record our learnings in the work of each work group, each of the work groups has the structured problem-solving document like this one. And this serves for the work group as a one-page overview of the work and their thinking. And there are supporting documents that go into more detail for each of these sections. But this is the Address Poverty and Enhance Self-Sufficiency Work Groups document. And then on the left side of the document, this is really kind of them understanding the issue. And this includes why this topic is of regional concern, what's currently happening, what improvements we want to see as a reflection by our future state measures. And at the bottom of the left-hand side is what the work group has identified that may be blocking us from improving or stabilizing our future state measures. And then if you go over to the right-hand side, this is really their solutions thinking. And these are approaches or methods that they agreed upon as a community that would impact our future state measures. And we call them the strategic directions. And you can think of this like there's spokes on a wheel with that future state measure at the center. And so those strategic directions are really the avenues for improving that measure or those measures. Right now, the work groups are working on their detailed implementation plan. This particular work group is releasing an RFP this month around increasing graduation rates. And then at the bottom is where the work groups will capture their shared learnings and make adjustments as needed. Right, Renee?
Hey everyone, so I will share what we are planning for the next 4 years. Next slide, thank you. This timeline reflects the addition of 2024 to the current RIP. We're currently on step 6 in structured problem solving, which is implementation. And that's in the middle yellow section of the timeline. The work groups are in the process of reviewing data for a deeper understanding of the future state measures. This will inform the development of their action plans over the coming months. These plans will include developing RFPs for grant opportunities, increasing support of existing work that will directly impact measures, and partnering better with those doing the work that are not currently part of the work groups. As we move forward, we will continue to review and revise our processes. Since we now have the additional year, the implementation work will continue through the beginning of 2024. In that final year, the work groups will transition to evaluating this RIP cycle and contributing to the next regional health improvement plan. So there will be some overlap as we wrap up this current RIP and start the next one. Next slide. So here are just a few examples of some of the emerging work that's coming out of the RIP implementation strategies so far. So the Address Poverty and Enhance Self-Sufficiency Work Group is planning to release an RFP to improve high school graduation rates through inclusive and collaborative partnerships with youth experiencing economic disadvantage. The Stable Housing and Supports Work Group is planning to invest in the development of regional housing council in order to align efforts across systems to address the housing crisis and homelessness. And the Substance and Alcohol Misuse Work Group is planning to release an RFP to accelerate systems, policy, and environmental change to make way for peer support services. As you can see, by working through the structured problem solving, the work groups are able to move from high-level strategies to specific actions that directly address the future state measures. And this will be their work for the next few years. So that's what we have, and we have, I think, a couple minutes for questions.
I've got a question. This is Brad. And I want you to know this isn't a criticism by any means at all. It's just a actual, curiosity. Why has so little of the funding from the work groups been dispersed?
So great question. So if you remember, especially it seems very visible on the image that was shared. So that's 5 years of funding, and we're starting in for year one. We recognized that the first year is really around the preparation to implement. It's like the starting slow to be able to go fast. And so that's what you're seeing. The funds that have been spent have been through the mini grant process, which is a new process to hit immediate needs and capacity building, but also still to really focus on the future state measures that are our guide. And so that's where it appears that there's been a less amount of funding, though we're still meeting most of our benchmarks for that. But it's prepping us for being able to really do larger investments in the next couple of years. Process-wise, honestly, we've had a lot of learning around how do we bring in, broader range of partners into this work? How do we do it in a different collaborative manner? We've already started reflecting, what does this mean for the next drip cycle? What are we going to tweak to be able to adjust for speed? Recognizing that really what's important is like relationships and trust and some organized approach. So sometimes we tend to compromise what's important for, speed and deadlines.
Gwen, can you talk with us specifically about how you do outreach to non-traditional partners beyond nonprofits, maybe the business community, Chamber of Commerce, law enforcement, whoever?
Good question, and I'll allow my colleagues to chip in too. That's something that we're starting to do, especially before COVID, on a one-to-one individual basis. It's through our network of other community partners referring folks to us and us to other folks. So it's been very organic, one-on-one personal nature. We are doing work in the next year or two around how do we more strategically and intentionally reach out to folks that we haven't traditionally partnered with. So that's very much work to come.
Hey, Gwen, this is Dan. Sort of a question that is related to Brad's, or maybe Brad's leads into, and you might have even mentioned it and I missed it. Do we have some kind of timeline guardrails in the process on an annual basis to adhere with OHA's expectation of the timeliness of getting funds into the community?
Absolutely. And I'm going to refer to Donna because we've done a lot of work on the back end of this, and she'll be able to articulate it much better than I can.
Yeah, great question, Dan. And thank you, Gwen, Renee, and Michaela. Great presentation. We do have, it's kind of interesting because as most people may or may not know, another one of the criteria in our joint management agreement is that we will have the 1% RIP funding that we receive on a monthly basis throughout the year spent into the community by March 31st of the following year. So the expiration date on those funds, if you will, that we received in 2020 is March 31st of 2021. And so there is also some managing, a little dance that we do to make sure that funding's out the door as well. So to your point, Brad, there is a little bit of I just like to call it an expiration date on those funds that we need to have them out the door. And we will meet that requirement for 2020 and look to meet that requirement in every subsequent year. Is that helpful, Dan?
Definitely, thanks.
You bet.
Okay. Any other questions? We're at time. So this is ruining my reputation. I base it on ending early. So my forgiveness, I'll do better next time. So that's a joke. Any other issues for the board? Hearing none, can I have a motion to adjourn?
So moved.
And Justin waved that he was second. So all in favor? Aye, aye.
Hey.
Okay, thank you very much. Good meeting.
Thanks,
Appreciate it.
everybody. Have a great afternoon.